Good afternoon. This afternoon we are discussing biologics, the new frontier. And the biologics we will be discussing this afternoon are more of the biologics we use in inflammatory bowel disease. Okay, so excuse me. Um, okay, doesn't flip. Ayaw man, ayaw mag-change. Okay. Okay. So learning objectives for this afternoon, we're going to review the mechanism of action of your biologics, especially in inflammatory disease, discuss the indication, how they work, and of course, discuss strategies to optimize the use of these biologics. Later on, we will discuss adverse drug reactions associated with biologics and how to mitigate these effects. After we've discussed biologics in IBD, we will have Dr. Feliciano, actually a rheumatologist, give a reaction to this. And why would you say rheumatology? It so happens that the same drugs that we use, okay, anti-TNF agents, are also drugs that rheumatology use. And when you look back, most of the practices, okay, that we use here in GI are actually lessons also learned from the use of the rheumatologists of these biologics. Okay. When we speak of biologics or biologic drugs, we're actually speaking of medicinal products or vaccines that are grown or produced in your living organisms, as opposed to your usual drugs, which are chemical synthesized from one chemical. Okay. Now we have biologically proteins. Okay. You make a gene, you transfect an organism or the host cell, and you trick this cell to produce the protein for you. You have a cell line, make more of these uh, cells, and trick them to become mini factories for you to produce your desired protein. The desired protein is now purified, and afterwards you get your final product. Now, categories of your biologics will include hormones, growth factors, vaccines, and proteins. But what I'd want you to look on would be monoclonal antibodies, because these are the things that we use in inflammatory bowel disease. When you think of IBD, for example, okay, why does it occur? What we would usually tell you is that you have a genetically susceptible host, and now he is exposed to the environment, could be bacteria, and somehow you have a dysregulated immune system that happens. One of the things that are produced is TNF, okay? And tumor necrosis factor is actually a cytokine produced usually by your macrophages, and then it signals other cells, okay? Your T cells, your beta cells, hepatocytes, and fibroblasts, and somehow all these cells are involved in your inflammation, okay? Your T cells will proliferate, be in charge of your cellular mediated immunity. Beta cells, for example, are stimulated to form your antibodies, and you sometimes have even apoptosis for your fibroblasts. So if you can inhibit your TNF, okay, then you block a inflammation. So when we look at your anti-TNF agents that are used in inflammatory bowel disease, we think of infliximab, adalimumab, and golimumab, and certolizumab. Infliximab is a chimeric monoclonal antibody, okay? And it was, of course, the first monoclonal antibody that was used or developed. Later on, you have adalimumab and golimumab. These are mainly humanized monoclonal antibody. Your certolizumab is actually a FAB fragment, okay? And it has a polyethylene glycol backbone. Because of this backbone, there's in terms of one of the advantages for this drug would be it doesn't pass the placenta, and it is one of the drugs you would consider probably if you were to give a patient if you were considering of giving a patient, pregnant patient, anti-TNF factors. Okay, the infliximab or your anti-TNF agents can either bind to those which are floating around, okay, or on the receptors in your target cells. Now, the other class of drug that is involved in inflammatory bowel disease or used in inflammatory bowel disease is anti-integrin inhibitors. And you have to go back a little bit, okay? Now, these are integrins would affect more of your leukocyte migration. So, for example, you have these lymphocytes rolling along, okay? But in order to go into the cell, into the vascular endothelium, it has to pass, okay, through the vascular endothelium. So, what happens? It rolls around, gets tethered, okay? It stimulates your integrin, okay? Basically, for your gut epithelium, vascular epithelium, you have the alpha 4 and beta 7 integrin, okay? Which stimulates now your MADCAM1, okay? Which will cause your lymphocytes to adhere onto the wall and thereby pass through into the cell. Now, if you can, okay, inhibit the migration, okay, then you have a powerful agent again to stop inflammation. Okay. Now, we have an integrin inhibitor which came out. You have vedoluzimab, and vedoluzimab targets your alpha 4 beta 7 integrin heterodimer. And the beauty of this is your alpha 4 beta 7 is a integrin that is located mainly, okay, in your gut vasculature, okay, and that is the reason why it's selective. Natalizumab is another anti-integrin inhibitor. The problem with natalizumab is it binds to other, okay, alpha integrins, basically your alpha E beta 7 and your alpha 4 beta 1. Now your alpha 4 beta 1 binds to your VCAM and it's found in your brain, okay, so that in cases of natalizumab, you have the risk of having PML, okay, progressive multifocal leukoencephalopathy, and that's one of the reasons why we've shied out on using natalizumab. Okay. So biologics for UC, as mentioned earlier, you have your anti-TNF antibodies, infliximab, adalimumab, and golimumab, which we use in ulcerative colitis. In patients with Crohn's disease, for your anti-TNF agents, we have your infliximab, adalimumab, and your certolizumab. Vedoluzimab in your Gemini studies has shown to be effective for both your ulcerative colitis and Crohn's disease. Okay. In terms of comparing the efficacy of the anti-TNF agents in Crohn's disease, okay, there are more similarities than disparities actually. Okay, the ACCENT trials, which use infliximab, your CHARM studies, which use adalimumab, and PRECISE studies, which use certolizumab. What we see is that you have clinical remission is induced approximately in 60% of your patients over the first 6 to 12 weeks. However, only approximately 25 to 30% of the patients will have steroid-free remissions at the end of the year. Okay. Now, when we look at the efficacy also of anti-TNF agents in ulcerative colitis, again, in your ACT 1 and 2 trials, using infliximab, ULTRA studies using your adalimumab, and PURSUIT studies using your golimumab, approximately 40% of the patients will have clinical remission induced within the first 8 weeks, but only 30% of these patients will have steroid-free remissions at the end of the year. Okay. How about for vedoluzumab? Okay. Admittedly, there's no direct or indirect comparison studies between your anti-TNF therapy and natalizumab, or vedoluzumab for that matter. However, what we can say is both drug classes demonstrate efficacy for induction and maintenance of remission in both ulcerative colitis and Crohn's disease. Having said that, okay, you have to remember that with vedoluzumab, there's delayed onset of action. In the Gemini studies, they checked whether they're responsive, response rate by 6 weeks, and they found out that there was no response at that. FDA would say that you repeat or you get review response rate by week 14. Okay. Now, who are the candidates for biologic therapy? There are several classes of drugs that we use in inflammatory bowel disease. You have, of course, your 5-ASAs, your steroids, immunomodulator therapy, and now your biologic therapy. Traditionally, we use your biologic therapy for steroid refractory disease or who are refractory to the use of or patients, for example, may refuse. Um, this is, when we look at it, the conventional or the basically using this approach, we reserve biologic therapies for patients who have not responded to azathioprine and corticosteroids. However, that has placed into question, okay, because um, limit we might be missing on patients, okay, who should be given biologic therapy. A study by Hans, for example, using top-down. When you say top-down therapy, you are giving early on your biologic therapy in your patients. So in this study by Hans, okay, he ran had a randomized controlled open label trial, which he placed patients on conventional therapy, okay, meaning to say patient was given corticosteroids, then afterwards tapered down. If he had a relapse, was given again corticosteroids with immunomodulators. If at 16 weeks, okay, there was still no good results, then that was the time that you would be given infliximab or infliximab, okay? And
Okay, we are having connection problems. Okay, we will have to fix.
okay. Well, apparently we had audio problems earlier. Right now, I hope you. I'll start where. Well, I don't know where but I'll start, for example, from on this slide, wherein I was discussing patients on conventional therapy and early remissions, not to mention with endoscopic healing. What we'd like to say the resolution remission, meaning to say, okay, without giving and stenotic lesions. Smoking, because certainly okay, antibodies. Okay, start convincing your patient, especially for anti-TNF. The risk for you developing problems with your steroid-resistant colitis. The first thing you need to do is tuberculosis can also have non-cachetes, and they're usually noted in the retroperitoneal and mesenteric region. Uh, Even given these things, okay, clinically it would still be difficult to differentiate your GI tuberculosis from your with empiric treatment of your GI tuberculosis. Uh, if the patient does not respond, it is only then that we start anti-TNF therapy. Okay. Hepatitis B is prevalent again in the Philippines. And if you give anti-TNF agents, okay, to your patients with hepatitis B, in two retrospective series, it's been noted that you can reactivate your hepatitis B. Okay, in one series, there might be a dysfunction. In one series, they showed something like 25 to 30% of these patients can have liver dysfunction. One series showed 50% of the patients reactivating. Okay, and of course, one patient died in that series. Okay, so check your serologies. You check your HBs antigen. If it's positive, then you'll have to determine whether this is acute or chronic hepatitis B. If this is acute hepatitis B, then biologics should be delayed or stopped until resolution of the acute infection. If you have chronic hepatitis B, even if you were a carrier, for example, then you know that you most likely will reactivate while on anti-TNF therapy. Then you give prophylactic antiviral therapy. You give a nucleotide or a nucleoside analog 2 weeks before the introduction of your biologics and continue until 12 months after withdrawal. We usually give entecavir or tenofovir. These are nucleoside analogs, which are potent. Not to mention, they have high threshold for resistance. Okay, so especially in these patients where you want most likely a fast-acting nucleotide analog, and you're going to give these anti-TNF agents for a very long time. You cannot give interferon, okay, to your patients. One, interferon itself can reactivate your Crohn's disease. Okay, not to mention you can have bone marrow suppression with Crohn's disease, with interferon. How about if you have a patient who is S antigen negative? It is seronegative, including your anti-HBC, then you vaccinate your patients. It is important to remember that when you use an anti-TNF therapy, um, it's important that they reach, that your goal should be more than 10. Okay, you're actually aiming for more than 100 IU per ml. Why? Okay, because you can lose, okay, your protective antibodies through time. Okay, and it's even said that you need to check your anti-HBS titers every 1 to 2 years to make sure that you still have protective antibodies. If you have patients which anti-HBC positive, even though they're HBS antigen negative, you might have occult hepatitis B infection. Having said that, the reactivation rarely occurs, and as such, you do not need to place these patients on prophylactic uh, therapy. What you would need to do is to monitor your AST, ALT levels and your hepatitis B serology every 2 to 3 months. Okay. It's important to vaccinate your patients. Okay. We've already mentioned that there's a high risk of getting infection in patients on anti-TNF therapy, especially if this is done in combination with your immunomodulators. So the best time to actually vaccinate your patients is before you even start your immunosuppression. You certainly cannot give your live vaccines, okay, while you're on biologic therapy. Give these patients annual flu vaccine and, again, pneumococcal vaccine. What you prefer for your pneumococcal vaccine is to give your combination therapy, your SB23 and your PCV13. Usually you give your PPSV23, and then a year after you give your your PCV13. Okay. Biologics are immunogenic. Admittedly, it's understandable in infliximab, which is a chimeric monoclonal antibody with human and mouse components. But being big proteins, your biologics, all biologics are immunogenic. And what does it mean? Since they're immunogenic, they're prone to develop anti-drug antibodies, which can impair the binding of your biologic to the target cytokines, making it ineffective, or it can also accelerate the drug clearance of these biologic agents. What it means is you have a less uh, you have a less potent, okay, less agent. Okay, so it's important to maintain drug levels. Why? You need a specific level of monoclonal antibody to bind your target, either your TNF or your integrin. When blood levels fall, it's been shown that disease will relapse and um, your antibodies develop. When your antibodies develop, then you're prone to having infusion reactions, not to mention, again, well, less mucosal healing. So you have to maintain that level to prolong your clinical remission and, of course, promote your healing. There are some instances where drug clearance is increased, low serum albumin, where you might have very severe disease and you're now throwing, okay, not only albumin in your stools, but even your monoclonal antibodies. Okay, high CRP and high baseline TNF would just say that you have a lot of inflammation going on, and therefore a lot of the antibody is needed. Okay. So in those situations where you have, for example, high CRP, high TNF, low albumin, these are the situations where you might need to monitor the levels of your drugs. Not to mention, you might need to give higher doses, okay, of your drugs, of your biologics. Okay. So what are the strategies to maintain the drug level? Uh, we'll mention about scheduled versus episodic infusions. When we were first starting to use infliximab or the other TNF agents, what was usually done was to give them episodically, meaning to say there was no maintenance therapy afterwards. And as we've always said, I mean, there are higher incidences of infusion reactions, not to mention higher a tendency to develop autoantibodies. In infliximab, for example, if you give it uh, episodically, then there's a chance 60% of your patients will develop your antibodies. But when you maintain this patient on scheduled regimen, maintenance regimen, then the percentage of patients who develop antibodies falls down to about 10 to 20%. Okay. Concomitant suppressive therapy, I guess this would be your SONIC trial uh, and your success trial. In the SONIC trial, what was done was patients were given either azathioprine monotherapy, infliximab monotherapy, and a combination of your infliximab and your azathioprine. And what you see is if you give combination therapy, okay, then there are more patients who have corticosteroid-free clinical remissions and also more patients with mucosal healing. What is thought of is that your immunomodulators, your azathioprine, will decrease or suppress the chance um, of your patients developing antibodies. Okay. Nowadays, your choices for your immunomodulators, you can of course choose either azathioprine, you can choose uh, 6-MP. The other new thing would be using methotrexate. Okay. If there's no response to your biologic therapy, what do you do? Okay, then the things you have to think of is there might be low trough levels, there might be antibodies, or well, there are other pathways that can drive this. Okay, so what would you do? First of all, if you have, for example, steroid-resistant colitis or, for example, severe colitis, first you rule out infection. Okay, you check that there's no CMV, there's no C. difficile. Once, if you've ruled that out, okay, then you'll have to think that the exacerbation is due to active inflammation. Of course, if there's infection, then you have to treat the confirmed infection. Okay. If there's active inflammation, the thing you do is to measure your drug trough levels and your anti-drug antibody test. If your drug trough levels are therapeutic, then it means, yeah, you've got a disease which is resistant to the TNF. You either switch class or you switch to another TNF agent. If if the drug levels are low, then you optimize it by either increasing the dose of the drug, or you shorten the interval at which you give it, or you give, if you haven't started immunomodulator therapy, give immunomodulators. So we're almost coming to the end of this lecture. We've already presented to you that there are two drug classes which we use in your in inflammatory bowel disease, your anti-TNF agents and your anti-integrin, okay, agents. Both are all similarly effective. Both are all immunogenic. Okay. Um, One advantage, of course, of your TNF is you have drug levels available, something that's not available for your vedoluzumab. Anti-TNF agents have important black box warnings. Okay. If you were to choose whether you're going to start anti-TNF versus your anti-integrin agent, depends. You have to choose the route. As I mentioned earlier, patients who can go to the hospital and get every 8 weeks IV infusion might choose your IV therapy. Okay, there are some patients who do not like to go to the hospital. Okay, then yes, they can use the sub-Q route. Okay, patients too, for example, who cannot stick themselves. Okay, you know, patients, for example, diabetics who cannot get lantus. The same thing for patients, okay? They might not want to stick themselves, then the IV route is possible for them. Anti-TNF, especially your infliximab, have rapid onset of action. You have studies, of course, that um, wherein immunomodulator therapy can be combined with your anti-TNF. You have your SONIC trials and your success trials. The thing, though, that you have to remember with your anti-TNF is the risk of infection and, of course, the risk of lymphoma is there. As opposed for your anti-integrin, okay, especially your vedoluzumab, only given IV, there's delayed onset of action. Presently, there's no studies, at least, showing if there's an advantage of giving immunomodulators to your vedoluzumab. But if you look at retrospective trials wherein vedoluzumab was given, okay, to patients already on on azathioprine, there was no well, increased advantage, at least in those areas, in the mucosal healing or in the response rate. Okay, biologic agents should be given to patients with moderate to severe disease, especially if you have patients with aggressive variables. Okay, patients, these are the patients most likely need early biologic therapy. Our target should be mucosal healing because mucosal healing translates to patients with less hospitalization, less relapses, okay, and less complications or surgery in the future. Having said that, okay, if we cannot achieve deep mucosal healing, at least we should have clinical remission and endoscopic remission. Okay, right now there are a lot of studies, drugs being developed to for inflammatory bowel disease. Uh, we hopefully have a greater understanding of the pharmacology and pharmacokinetic properties of these drugs so that we are now ready to individualize therapy for our patients. Thank you.
Thank you very much, Dr. Nina. Before we proceed to our Q&A portion, we would like to introduce our reactor. Um, Dr. Raul Feliciano also graduated with our class from the UP College of Medicine, class of 1990. He did his residency in internal medicine at St. Francis Hospital, Evanston, Illinois, and his fellowship in rheumatology at the University of Illinois in Chicago. Let's now call on Dr. Raul Feliciano, from the medical field.
So, good afternoon. Can you hear me?
Yeah.
Can you hear me? So good afternoon. So the talk today, we've seen that advances in molecular biology and understanding of the pathogenesis of inflammatory conditions, particularly inflammatory bowel diseases and inflammatory arthritis such as rheumatoid arthritis. So certainly a new generation of innovative therapeutic interventions have now replaced the old. And none of the old drugs can match the power and bioselectivity of these biologic agents. And in a way, they provided insight into the disease process itself. The last 10 years, we've seen an explosion and an expansion of biologic agents available for treatment of inflammatory bowel diseases and inflammatory arthritis. In fact, it started off with just two TNF-alpha inhibitors barely 15 years ago, and now there are more than 14 different biologic agents available. in the market, and several more in the pipeline as we speak. They target key proteins and molecules in the inflammatory cascade. No? So they can actually be T cell, they can be B cell, or cytokine targeted therapies. So this gives the clinician a multitude of treatment options in the care of their patients. However, of course, with these options comes the challenge to maintain a level of expertise in prescribing and monitoring these drugs. The webinar today gave us a better understanding of the function and indications of biologic agents in use in inflammatory bowel diseases. So just as important, well, these new treatments are enthusiastically welcome. They're also sort of inside concern and caution, which is just normal, given that there are new treatment modalities. So for my time today, my reaction today, I just want to touch base on three key issues. First is, are these agents really effective? And the answer is yes. Repeated studies have shown and consistently shown that biologic agents significantly reduce disease activity in inflammatory arthritis, especially rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. And certainly there are more results are way much better compared to old treatment modalities in the past, such as the usual disease-modifying agents. Another key endpoint that we always want to see when we look at studies is, do they halt or alter the progression of the illness? And certainly they do. Studies have shown that all biologic agents inhibit or retard radiographic patients with rheumatoid arthritis and psoriatic arthritis. The results aren't as robust in ankylosing spondylitis, though. And lastly, patients treated with biologic agents have increased functionality and are more likely to stay employed, and also have less cardiovascular mortality. So these all translate to a better quality of life. So we see here that the use of TNF-alpha inhibitors and biologic agents have indeed delivered on the outcome measures that we want to see. And certainly they have become key drugs in the management not only of inflammatory bowel diseases, but also inflammatory arthritis such as rheumatoid arthritis and the spondyloarthropathy. Secondly, I just want to discuss a little bit on two other biologic agents that were discussed previously and have been used more frequently and have gained their own reputation. One would be tocilizumab. Tocilizumab is an IL-6 receptor antagonist. We all know that IL-6 is a key enzyme in the pathogenesis of inflammatory synovitis and destruction of bone and cartilage. So this is a new biologic that's been available maybe the past 5 years, and it's been approved for the use in rheumatoid arthritis and juvenile rheumatoid arthritis. It has not shown to be effective in patients with spondyloarthropathies as opposed to TNF-alpha inhibitors. And the second biologic agent that I just want to mention would be rituximab. So it's a little bit different because what we have discussed before were cytokine-targeted therapies. They target specific cytokines such as TNF-alpha, IL-6, tocilizumab, and there's also other biologics that target IL-1. So TNF-alpha, IL-6, and IL-1 are the usual inflammatory cytokines that are targeted using biologic agents. What is unique with rituximab is it targets the B cell. So rituximab is important in diseases wherein B cells play a major role in its pathogenesis. So it's been approved in use in rheumatoid arthritis, vasculitis, and also in certain cancers like lymphoma, and also certain major organ involvement in lupus. It targets the CD20 molecules on the B cells. Just two quick notes regarding rituximab. They've been shown to have higher rates of hepatitis B reactivation as compared to TNF-alpha. So rates of as high as 5 to 10% of resolved hepatitis B reactivation with rituximab. So certainly a more vigilant screening on patients with hepatitis B. And what has been mentioned about the anti-integrin and the risk of PML, rituximab has also shown a few case reports of increased risk of PML, as what Dr. Nina had discussed before. So again, caution in using these patients and these side effects. And lastly, I just want to touch base a bit about screening and monitoring of such patients. We couldn't emphasize enough the importance of screening for infections, as these agents certainly suppress the immune system. So active infections should be diligently screened for, as well as chronic ongoing infections. So in the presence of active infections or chronic ongoing infections, these agents are absolutely contraindicated. Dr. Amina had discussed at length screening and treatment of patients with TB and hepatitis B. Basically, I don't think I need to expound on that further. Regarding malignancy, TNF-alpha is important in inducing apoptosis in tumor cells. So there's been reports of increased risk of lymphoproliferative disorders and lymphomas in patients taking TNF-alpha inhibitors, and therefore they're contraindicated in patients with a history of lymphoma or lymphomuscular disorders. Also, they've shown increased risk for melanomas, as well as non-melanoma skin cancer. So they're also contraindicated for patients with a history of melanoma or non-melanoma skin cancers. But they have not shown they did not show increased risk for solid tumors. So they're actually safe in patients with solid tumors, but although some experts would recommend that they be at least cancer-free for 5 years before they be started on TNF-alpha inhibitors. And also a little bit on demyelinating conditions. There's been some case reports of increased risk of demyelinating diseases such as multiple sclerosis, GBS, optic neuritis in patients with TNF-alpha. So in patients with such conditions, these agents are certainly contraindicated. And in fact, some experts would recommend in patients with a high risk or strong family history of demyelinating conditions to screen them for an MRI of the brain, and if you see silent lesions or occult lesions, then they probably wouldn't give in this subset of patients. Also these agents are contraindicated in patients with congestive heart failure class 3, class 4. So what do you do in this subset of patients? Maybe we can use other biologics that don't have increased risk for CHF, don't have increased risk for demyelinating conditions, a lower risk for malignancies, and these are would be your tocilizumab and your rituximab. So maybe that would be a better option in this subset of patients. So I think, and lastly, so the safe use of these drugs not only requires knowledge and experience, but it's also bolstered by guidelines and rules that we can follow. So certainly there's several scientific groups and subspecialty organizations that have come up with their own screening and monitoring of patients, and these are readily available. And we can easily get hold of these, and so that will guide you as to how to use these medications better. So drug safety must also be weighed against the severity and risk of the disease under treatment, but it is also just as important not to underestimate the impact of uncontrolled disease in decision making. I think that's, yeah. Thank you.
Okay, thank you, Raul, and thank you, Yvonne, for that positive discussion on biologics with emphasis on inflammatory bowel disease. So we are now open for questions. We may be able to answer only a few questions as we have limited time. So first question, may I ask which biologics are available in the Philippines and are the cost of biologics for one treatment course? Dr. Mina?
What we have right now would be, I don't have the cost because we have infliximab and adalimumab here in the country right now. Raul, would you
how
about you?
Yeah.
Rituximab, I think it's biosimilar.
Sorry, I didn't hear the question.
the cost.
which is available right now. We do have infliximab and adalimumab here in the country, actually.
Yeah, there's
There is
infliximab.
there's going to be vedoluzimab study that's going to be launched this for IBD. So
There's also etanercept. It's a TNF-alpha inhibitor, but it's a soluble. It's a difference. It's not a monoclonal antibody. So unfortunately, Dr. Amina had not mentioned that because it's not recommended for inflammatory bowel diseases. It's not as effective as infliximab. I think Dr. Amina would agree that etanercept is, I think, not approved, right, for inflammatory bowel diseases. Yeah, it's not yet, but it's also a TNF-alpha inhibitor. Yeah, other biologics like rituximab, IL-6. But if you're just TNF, yeah, I think those are the only three that are available. There is ustekinumab actually, which is for psoriatic arthritis. That is against IL-12 and IL-23. That's also available here in the market, here in the Philippines.
there are ongoing studies actually for using ustekinumab for possibly for IBD, but still not released for that indication.
Yeah, because ustekinumab is only approved for psoriatic arthritis. It's not yet approved for rheumatoid arthritis and the other inflammatory arthritis.
Okay. For rheumatoid arthritis, may I ask your patient, what is the cost of treatment for biologics, like infliximab or other biologics? How much will it cost to have a treatment course?
They can range depending on the obviously depending on the biologic agent. They can cost anywhere from 30,000 to 60,000 a month. So it's quite expensive. Yeah.
I hear that they are covered by the corporation. But in the Philippines, is there a chance that the health will soon cover for biologics?
I'm not from.
I don't know, but even in the United States, there's, I mean, there is always a question of insurance covering biologics for these patients. So I don't think it's going to be happening here. Happening soon.
But it is indeed covered in the U.S. So that's why you'd be very fortunate if you're you're an American citizen. These are covered by HMOs, by insurance companies in the U.S. There just has these certain strict guidelines that needs to be followed when prescribing this medication. It's just not, you just can't prescribe them just like that. You need to sort of a set of criteria before you can. This will be covered.
Okay. This may be the last question to be answered by both speaker and reactor. What is the worst complication that you have encountered in a patient that you have given biologics, and have you handled it? First, Dr. Mina.
Nothing that was well, TB. There was a reactivation of TB. She was actually treated for TB in the past, so she had gone through the recommendations of screening and all that, but she still developed TB. But she got better with stopping of the biologic and anti-TB treatment. And infections, nothing really serious, but a few patients have had some infections like pneumonia, UTIs, but nothing very severe.
Dr. Mina?
I would still say infection would still be the more common adverse drug reaction that we see. Having said that, actually the most common problem I have actually with patients who I've started sometimes on the on the agent is for them to maintain because it's costly. So some of these patients might not be able to do maintenance therapy. Okay, in connection to that, I guess it's one of the questions that always come up during is will will they be able to stop? Because if you note, we do we do the induction therapy, then afterwards place them on maintenance therapy. Okay. Of course, there's some reports that for rheumatoid arthritis and sometimes for IBD who have already achieved mucosal healing, that you might stop. No, but we do know that they can relapse. If they relapse, yeah, then we might give them another dose again. We start again the anti-TNFs. I guess a question for, because we learn actually more from Ruma. Um, how about who are the patients you've stopped biologics on, or you maintain them forever?
The recommendation is maintain them forever because these are not cure. These
Yeah, the
medications
relapse rate.
they're not cures. No? So you're just basically controlling the disease. So eventually, once you stop them, the disease will come back. But the thing that I've noticed is the disease does not come back right away. As opposed to, let's say, methotrexate or other oral disease-modifying agents, when you stop them, they usually get a relapse weeks or months or even weeks, as short as several weeks. What I notice about biologics is, especially when they've been on it for a long time, that when you stop it, they don't relapse right away. So, you know, that's still a plus because certainly because of the expense, you want them to be disease-free for the longest amount of time, right? Because it's no expensive medication. So yes, we don't normally, it's not recommended to stop. But if you do stop them, then there should still be oral disease-modifying agents on board. Like you don't stop your methotrexate, you don't stop your sulfasalazine or anything that they're on when they were on the biologic agent. By the way, you can actually, for some biologics, the use of disease-modifying agents is recommended. Especially, for example, like infliximab, like Dr. Mina had said, because of formation of anti-chimeric antibodies. So disease-modifying agents actually prevent formation of antibodies. These are true for biologics that are chimeric, part mouse, but fully humanized, such as adalimumab, you don't normally see production of antibodies.
Okay, thank you for that engaging discussion. And if you have more questions, you can email us at webinars1@gmail.com. That's all the time we have for this webinar. So we'd like to thank our speaker, Reactor, and our sponsor, Johnson & Johnson. After the session, we will be sending a survey link to the participants. Please answer the survey. You can assess our webinar. We will invite you to our next webinar on January 6, 2016. There's also Wednesday, 12 noon to 1 p.m. and 1 to 2 p.m. The topic would be asthma from 12 to 1, area from 1 to 2. And our speaker for both is a pediatric allergologist in the Medical Center. May we also invite everyone to register to our CMA conference on December 15th at the Hall at the UP College of Medicine. You can also live stream at livestream.upm.edu. So in behalf of the UPCM Class 1990 and the UP Medical Alumni Society, we would like to thank our sponsors and all our collaborating units, the Health Center, ISF, Medicine, Medical Informatics, USP, SP, and Mr. Lisa Hat, our host. This is Dr. Henrina, together with Dr. Mina and Dr. Mina and the UP Network closing this session. We hope you have learned a lot from today's webinar.